We were treating acute myeloid leukemia in 1977 with 7 and 3.
Right.
We are still doing the same in 2018. My question is,
Right.
what is the best way forward to change it by 2028?
I think the big problem is that we get stuck with our language that we use to describe diseases, and the language starts influencing our thinking rather than the thinking influencing our use of language. And what I mean by that is leukemia is a disease of abnormal white cell proliferation. And we use terms like hyperproliferation, for example, increased cellularity, for example. And those terms convince us that we're right, that that's what it's a disease of. And we're not thinking about the big picture. We'll take solid tumors, which I know much better, in this regard. Clearly, proliferation is an important component. If cells don't divide, they're not going to have too many cells. But when you look at your average breast cancer, its percentage of dividing cells is lower than a gestational breast, for example. So it's not cell division that's the problem. And yet, nevertheless, we use the same terminology, and therefore we get stuck with anti-mitotic drugs. 7 and 3 is an anti-mitotic regimen, and yes, indeed, we kill cells. And we try to drive toward killing all the cells, which actually is mathematically impossible. Goes back to Howard Skipper, and it goes back to, and Howard Skipper worked on leukemia. Leukemia L1210 was the primary model that Howard Skipper, Frank Schabel, Griswold, and colleagues really looked at in that setting. And they proved with proportional cell kill that you can't get rid of the last cell. It's actually impossible, mathematically impossible. These drugs kill a certain percentage of the cells that are present, not an absolute number. And as you decrease the percentage more and more and more, you're still left with the residual population. So other factors are coming into play that's giving to cure of leukemia, and those other factors are probably cell-cell interactions, microenvironment changes, and so on, which we can spend hours really talking about. So is the disease proliferation, or is the disease a misfunctioning of that complex of leukemic cells, of white cells, with other cells in its microenvironment? And are we just treating the obvious thing, which is the cell division part, without treating the real root cause of the disease? Occasionally we get down to a small enough number that those other factors play a role, but should we be looking at those other factors? And this is certainly true in solid tumors, where our cell kills are much less than we achieve in leukemias and lymphomas. So we have to broaden the definition. I mentioned earlier self-seeding as one phenomenon of cancer. So cell mobility is as important as cell division, but there are many other factors involved, and it's the communication between the various cells that make up the tumor, or the abnormal marrow, for example, in the case of leukemias, is that we really have to address. Part of the real problem is that because we were convinced, or we convinced ourselves, that cancer was a disease of cell proliferation, we developed experimental models that screened drugs for the anti-proliferative effect, and we also developed clinical trial designs that assessed the activity of our agents by the amount of cell kill, and we didn't look for some of those other phenomena. And that really is a real problem, because if I say, like in breast cancer, that I have an anti-metastatic agent, how do I test an anti-metastatic agent? If I can't make a cancer shrink and I measure duration of that shrinkage, I can't get approval of that drug. There's no clinical trial methodology that looks for anti-metastatic agents. And yet, if anti-metastasis, anti-cell mobility is a key to making progress, I'm not screening drugs for that. I don't have mechanisms of screening drugs for that, and I certainly don't have clinical trial designs. So I think that we really have to sort of get away from being stuck in the notion that cancer is a disease of cell proliferation, and not only think about other things, which many people are doing now. I'm certainly not the only one who's thinking in this direction, but developing the tools for being able to screen drugs for that activity and also test them in a clinical trial environment.
Thank you. Question number 2. Larry.
Right.
3.5 million papers published in cancer. 135,000 in 2017 alone.
Okay.
There is a staggering disconnect between great scientific insights into the biology of the disease and our ability to translate this into the improved treatments for our patients. What are we doing wrong?
I think we're doing a lot of things wrong. And first of all, great science is not necessarily great science that's going in the direction of improving prognosis for our patients. You can have great science, that's beautiful science, and we love it for the beauty of the science, but not necessarily getting us in the direction we have to go. I'm a big fan of basic science, and I think that's really where all the fundamental ideas come from. But we also have some selection factor for the ones that may actually, help our patients with cancer is going to be an important part of that. Often we're rediscovering the same thing over and over and over again. There are 5 enzymes that do something, so you publish a nice paper on the 6th, and somebody publishes a paper on the 7th. We're not really making an advance that could really help us in that direction. But I think that's not the big problem. I mean, you want to see unfettered science, you want to see unfettered creativity. That's not the real problem that I see. The real problem is that we don't have a good mechanism for getting really important observations up to the level that we could attract the funding to develop them as therapeutic agents or as diagnostic tools. Once something has proven activity, then the mechanisms work very, very well. Advanced biotech, large pharma, can take something that works and really drive it all the way to completion, develop it as a commercial entity and deliver it to the patients. And we'll leave the issue of drug pricing out of this for the discussion. That's another problem. But on the other hand, we know that there are mechanisms for doing that. We have a venture capital community that's actually very good at taking things that are very promising, that have reached a certain point, and developing up to the level that it can move into that other aspect of development. What we don't have is is a mechanism by which we can unleash the enormous positive power of business to take really early discoveries and bring them up to the level that they then make sense for a venture capital kind of investment. For a venture capital investment, you want to see 10 times or more return on investment in a fairly short period of time. What about things that take a little bit longer or have a lower return on investment because they're higher risk to move them forward? There's no real way of getting money into that process from a very early stage up to the stage that people can actually think it's a reasonable thing to invest in, because at that level your choices are to invest in a drug or invest in better running shoes or invest in something else that makes sense from an economic point of view. I'm talking about from a human point of view rather than strictly an economic point of view. Now, from an economic point of view, obviously a win is a win is a win. A very good drug that could be brought to the public, that's going to be successful for everybody involved. But how do you get it up to that point? And we haven't solved that problem yet. That's I think one of the biggest problems that we have to face is how to get very early things that are very promising, that are very high risk. And what I mean by return on investment, you don't have to win each one. Let's say you have 10 projects and one of them really pays off. Well, that one that pays off, then could the other 9 could fail, and you still can make a reasonable, although not adequate from a VC point of view, a return on investment to be able to move it forward. So we need a lot of research, and we also need ways of taking some of the most promising things that are high risk and developing to the point that the existing economic mechanisms of business development for agents can really take over. And we don't have that. I've seen over and over again really great ideas just die because they can't reach that point. I mean, you can just do a certain amount with grants in the hundreds of thousands of dollars. You need a few $1 million to take it to that point, and we just have no mechanism for getting that. So I think the biggest advance that I could foresee in terms of actually curing cancer is not a scientific discovery. We've got plenty of that going on. What we need is a better business model, and until we solve that problem, some of our very best ideas are going to die on the vine.
Very interesting. Very unique answer. Question number 3. The fact that children respond to the same treatment better than adults, of course, suggests that cancer biology is different,
Yes.
but also that the host is different.
Right.
Now, if that is the case, since most cancers increase with age, even having good therapy may not matter because the host is decrepit. Solution?
Well, I wouldn't say decrepit. I think that may not be the proper term. Obviously, it's different. I think I'll just give you a very good example of something we're working on right now. Is that with single-cell sequencing and microdissection, we've absolutely proven and published with extremely good authors and extremely careful controls that the majority of breast cancers, primary breast cancers, harbor mutant white cells. And those white cells have known oncogenic mutations. And so we actually have leukemic cells that are concentrated in the cancer. We also find that a very high percentage of people with all cancers have clonal hematopoiesis. They have these mutations that are circulating in very low titers in their circulation. But those cells, in breast cancer at least, and we're looking right now at lung cancer, we're looking at colon cancer, those cells are concentrated in the cancer, so they're doing something. And if you want an hypothesis is that what cancer is a mutant epithelial cell, a solid tumor, a mutant epithelial cell and a mutant white cell, and they shake hands and they both grow into a tumor. The tumor is as much these mutant white cells as it is the mutant epithelial cells, and it may be mutant fibroblasts, maybe mutant endothelial cells. That's all work that really remains to be done. Well, that's obviously a phenomenon of aging. As you get older, you develop mutations in your normal tissues. We know this for sure. The most mutated tissue in the human body are the eyelids. Almost nobody puts suntan lotion on their eyelids exposed to UV radiation. Lots and lots of mutations on eyelids. We know this from published work. And as we get older, we develop mutations in our white cells. All of us, after a certain age, have mutations in our bone marrow. We don't all have leukemia, thank God, but on the other hand, they're there and they may be doing something. And if you have, by random chance, the right mutation in your white cell and by random chance the right mutation in your epithelial cell, and they support each other, then they together form a tumor, and that's really what forms a cancer. Nobody ever died of breast cancer cells, which you die as tumors. And tumors are complex ecosystems of many different cell types. Now that's very different than the pediatric situation where we have driver mutations and we're discovering more and more driver mutations, and it is a disease of hyperproliferation. It is a disease where the cancer cell itself is the abnormal feature and the microenvironment may be much less important. And of course, if cancer is a disease of cell division, we've got very good drugs that kill dividing cells. Of course, we developed them that way. It's my previous answer to another question. And of course, they work better because of that circumstance, because the model applies in the pediatric situation, but the model may not apply in the adult situation, and to assume it does leads us into the situation we are today, where we have great responses and we don't have great cure rates for many diseases. So I think we have to expand our thinking, and in the expansion of our thinking, come up with novel ideas and also develop a business model so we can take those novel ideas and develop them to the point that the conventional mechanisms of commercial development can take over and we can have better therapies for our patients.
Great. I think you probably have answered my next question, which is that you have great knowledge and experience in the field. If you are given limitless resources to cure cancer, what will you do?
Limitless? Well, first of all, we don't need limitless. I mean, there's plenty of money out there to do this. It's just not being applied to the problem. All right, and I'm talking about things like sovereign funds, countries. I mean, there are a lot of countries out there that have really developed a lot of wealth, and that wealth is being invested in generating more wealth. Now, why wouldn't those countries want to be the place where cancer is cured? I don't understand why not. Wouldn't it be really nice to have the cancer cured from a country that has a large accumulation of wealth? And so what should be done is that money, and I'm not talking about really that much by standards of large sums of money, should do what I said. It should get together really smart people, should look for really early ideas that are high risk because they're very early ideas, but they're really smart, generated by people who have some kind of track record or not, or just a good idea of producing good things, and fund them as companies. And it could be a for-profit model. I don't care whether it's a for-profit model or it's a venture philanthropy model or the money goes back into the sovereign fund or individuals make money. It doesn't matter to me. But that it should be developed to the point that most of them will fail, and the ones that succeed will then generate sufficient funds that it makes sense from a business model. Now, I'm not the one who came up with this. Andrew Lo, who's is a professor of financial engineering, Sloan School of Business at MIT, one of the smartest economists around, has actually worked out the numbers. And the numbers really do work. With sufficient money and sufficient guidance, it's almost guaranteed. You never guarantee anything, obviously, in real life, but almost guaranteed that you're going to turn up really exciting new ideas that could not be turned up by any other mechanism and develop them moving forward. So that's what has to be done. We have to channel the existing funds that are out there in the world, in large hedge funds, in sovereign funds, and in other sources, of money that have been accumulated, and really use that power to really make a difference. And it can be done. The ideas are out there. I am convinced that the cure for cancer is already known. We just don't know it. And it's sitting around in an observation in a laboratory somewhere, and it may never be developed, and that's just an incredible tragedy. And I would also say what I said before when I started this conversation is that curing cancer, the same drugs, the same approaches may work for Alzheimer's disease and for Parkinson's disease, for plaque in coronary arteries, for renal disease. Mechanisms of damaged cells surviving may be a common mechanism for a lot of these diseases, or most of them. And so as we understand the process better, I mean, for example, the clonal hematopoiesis that I mentioned, the fact that we have mutant white cells circulating around, that's a risk factor for coronary artery disease, as well as a risk factor for hematological malignancies, and we're looking into it as a risk factor for developing solid tumors as well. So all these things are connected. We have the ideas, we have the people, the money already exists, all right, it's not being applied to the problem. So if I had, and not unlimited, but if I had access to those kinds of funds, setting up something like that would make an enormous amount of sense to me and would really make a difference in the world.
Thank you.
Thank you.
Last question.
Okay.
This is a philosophical one.
Right.
But because you're hands-on, always taking care of patients, you're the right person to answer it. Offering patients with advanced stage non-curable cancer, palliative but toxic treatments, is it a service or a disservice in the current therapeutic landscape?
I mean, that's a very complicated question because you can't answer it in generality. I mean, that's the kind of question that could only be answered one-on-one, an individual patient, an individual healer. One has to define what the goals are, and then one has to do what's necessary for the goals. And it could be adding a few months of life. It could be palliating symptoms. These are all possible. Taking a chance on something that's very risky but might make a huge difference. I saw that with Taxol. I mean, I very early on, with the drug Taxol, I had a patient who was really dying of liver involvement with breast cancer. And we had this conversation. To go palliative care, we tried this brand new drug that I have no idea if it's going to work, and we don't even know its toxicities yet. And she made the decision to go with it, and she got years of extra life, high quality life, by going with the agent. Those are the things that stand in the back of one's mind. So I think that you can't answer that in generality. I mean, it's a very individual, very personal decision that people have to make. And like all important decisions, it has to be made by a couple. It has to be two people having a conversation. The patient, who's an expert in their life, and the physician or the nurse or the healer that's an expert in biology and medicine. And they have to have a relationship where in a conversation they can come up with the right answer that's appropriate for that particular situation. I wouldn't want to see generalized solutions to something like that. It's a very personal, very individual, very intimate situation that has to be addressed and talked about in that context.
Thank you very much.
Thank you.
That was amazing. Loved all your answers.
Thank you very much. Thank you.